Good day, everyone, and welcome to today's webinar, Extreme Liver Surgery Around the World, hosted by the International Relations Committee. My name is Jessie Romans, and I am one of the committee administrators for the IRC. Before we get started, I want to inform everyone that today's webinar will be recorded and will be available for viewing after the webinar on the ACS YouTube channel. Additionally, if you have any questions during the webinar, please submit them through the Q&A box, as there will be a Q&A portion at the end of the webinar. With that, I'm pleased to introduce you to today's moderator, Dr. George Sulfas. Dr. Sulfas is Professor of Transplantation Surgery and the Chief of the Department of Transplantation Surgery at the Aristotle University of Thessaloniki School of Medicine. He has received the Edward E. Mason Award for Excellence in Patient Care and Education. He has published over 180 papers in peer-reviewed journals and PubMed, as well as 35 book chapters with an H index of 19. Dr. Sulfas has edited 6 books and is a reviewer of 30 international journals and on editorial boards of several others, including the International Surgery and the Annals of Surgical Oncology. He was the past chair of the ACS International Relations Committee and is currently the chair of the Greece chapter at the college. Additionally, he is a member of the Executive Council of the Hellenic Surgical Society and the vice president of the Hellenic Transplantation Society. With that, I'll now turn it over to Dr. Sulfas. Dr. Sulfas.
Thanks, Jessie, and thank you, everybody, for joining us today for the ACS International Relations Committee webinar on extreme liver surgery around the world. Today, we will hear presentations from Dr. Paul Daglina and Dr. Martin Hurdle on the rapid technique and small liver grafts, as well as ex vivo hepatectomy, respectively. After which, Dr. Yuman Fong will provide commentary. We will end up with a questions and answer portion for the full panel. Proceeding with our first presentation, Dr. Paul Daglina, it is my pleasure to welcome him today. He graduated from the University of Oslo in 1987. He's board certified in general surgery, vascular surgery, and transplant surgery, and a senior consultant surgeon within the fields of abdominal transplantation, liver, kidney, pancreas, HPB surgery, and vascular surgery. Since 2004, he has been director at the Department of Transplantation Medicine at Oslo University Hospital. He has a particular clinical and scientific experience and interest within the fields of liver transplantation, advanced HPB surgery, abdominal vascular disease, and liver transplantation for malignancy. The Transplant Oncology Research Group at Oslo University Hospital has pioneered the concept of liver transplantation for non-resectable liver metastasis from colorectal cancer and published numerous papers on this topic. He's a board member of the European Liver Transplant Association, associate editor of Transplant International and British General Surgery Open, as well as member of several international societies, including Transplantation Society, the ILTS, ESOT, IHPPA, the European Surgical Association, and the International Surgical Group. And we're very lucky and honored to have him today with us.
So thank you very much, George. I will share my screen to start the first presentation. So what I'm going to discuss is what we call the rapid technique for liver transplantation of small particle grafts. I have no particular disclosures. So during the last, let's say, 15 years, transplantation for malignancy is an emerging trend. And it goes beyond the traditional indications like hepatocellular carcinoma. We are seeing this as a more broad development. And this makes us face the problem of availability of grafts, particularly in this setting of patients not having liver failure, but having extended or experimental indications. Of course, you can try to alleviate this partly by make sure you use very stringent selection criteria. You might use extended criteria donors. One might also more systematically try to establish split liver graft programs, because we know a lot of the splittable livers are not really utilized for logistic reasons. And finally, living donor liver transplantation might be an option in centers practicing this. But the experimental nature of some of these indications really is a discouragement for doing living donor transplantation. So we began thinking about this about 10 years ago, and our basic idea was whether it's possible to use very small grafts in the setting of malignant liver tumors. It's standard of care to use segment 2 and 3 for a child, and then the extended right graft for an adult, with very little penalty for the adult recipient. So basically, the question was, could you actually use segment 2 and 3 as a surplus graft for an adult recipient? Obviously, you have two fundamental problems that has to be solved. If you put in such a small graft, we're talking about a graft to body weight ratio well below 0.5, maybe 0.3 to 0.4, you will for sure have postoperative liver failure. So that's the number one problem. The second problem is also well described in the literature, and it's called the small for size syndrome. It's basically a portal vein hyperperfusion syndrome with destruction of the sinusoids, which leads to hyperbilirubinemia and cytosynthetic failure and failed regeneration. So the further developed, the patients will usually die after a couple of weeks. So basically, the concept was published in 2015 called the RAPID concept, and this is an acronym for resection and partial liver segment 2-3 transplantation with delayed total hepatectomy. The principles used is that you have the patient with liver with tumors, and you start by doing a resection, preferably either 1, 2, 3 or left. And the aim of the resection has nothing to do with the surgical oncology. It's basically to provide space for a partial graft and to ensure that we have an adequate venous outflow. Then you have to make sure that you have a liver remnant to address the first problem, meaning that you can avoid postoperative liver failure even if the graft should fail. Then you transplant in the small graft, and the aim is to have a rapid regeneration. So you redirect the portal flow to the graft to stimulate fast liver regeneration. But at the same time, we want to avoid small for size syndrome. So the redirection of the portal flow to the graft should be done under close hemodynamic monitoring. So finally, you close up the patient, you do a graft volume measurements weekly by CT or MR, and the patient is ready for the second stage hepatectomy when the graft to body weight ratio is about 0.8 or approaches 35 to 40% of standard liver volume. Now, the hemodynamic assessment is very important. We know other augmentation methods like the ALPS technique, where they have never paid attention to this. So basically, when you have done the transplant, you have a steady state situation. You put in a pressure catheter in the portal circulation. and you insert flow probes to the portal vein and artery to the graft. And then you can do your trial clamping to make sure that the portal pressure after clamping is not too high. And the limit should be well below 20 millimeters of mercury. If clamping results in high pressure, you can do splenic artery ligation, you could do banding of the portal vein, or you could even do shunting. Because if you don't do this, you might have bad outcomes with small for size, and you might also have arterial constrictions to the hepatic artery, which might increase the likelihood of hepatic artery thrombosis. So this protocol has been adapted by 7 European centers that you can see outlined here. The first technical results was published around a year ago with 22 transplants performed. Here on the right-hand side, you can see an in situ picture with the 2 grafts. To your right is the graft, and the remnant is on the left-hand side, a remnant right liver, and you see the corresponding CT with the deportalized liver and a well-perfused small graft. In animal experiments, we have been able to show that doing the repeat technique gives superior kinetic growth rate and volume increase as compared to hepatectomy. And we have also been able to show that this also translates into higher IL-6 production and iNOS induction. In the clinical setting, all the patients have a tremendous volume increase in the course of 2 weeks. In fact, the median time to the second stage was 14 days. When this was compared to portal vein embolization or ALPS, you can see that the repeat technique far outperforms these augmentation techniques in terms of absolute or relative volume growth. Looking at patient safety, we had 1 death in this population, translating to a 90-day mortality of 4.3%. All patients succeeded in having the second stage, so the 1 patient dying had hepatic artery thrombosis 3 to 4 weeks after completing the second stage. There was no donor mortality in the living donors. So this has also now been published more anecdotally or as case reports also in patients with child A cirrhosis and HCC that haven't succeeded to get a deceased donor liver transplantation. All these transplants have been performed in Turkey. And in the setting of cirrhosis, I have not personally performed it in cirrhosis, but in the setting of cirrhosis, it's even more important to pay attention to the hemodynamics because these patients have portal hypertension. So all these patients have had portal shunts to manage this that subsequently are closed by the second stage hepatectomy. So quite recently, there was a consensus meeting on the rapid procedure for a day during the International Society of Liver Surgeons meeting in Zurich, Switzerland. And this was a consensus meeting according to the Danish model. And the meeting successfully provided a set of recommendations concerning standardization of nomenclature, appropriate selection of the recipient and the type of grafts, and optimized surgical techniques and the type of interventions needed. A dedicated registry is about to be formed to support this activity. So just to go back to the start of the concept, published in 2015, this is the very first patient in the world. He was at the time 50 years old male with a rectal carcinoma diagnosed in 2013. He had a T4 primary KRAS, BRAF wild type. He had all segment disease, was on third-line chemo. He actually also had a couple of small lung lesions that we decided to accept. He was operated in June 2014. He had a weight of 92 kilo and received just 330 grams of liver. This is the same guy from a newspaper article. He volunteered to half a year ago, and he's actually now this summer 10 years out, completely cured from his cancer by just 330 grams of liver. So these are his CT images from the time after the transplant. You can see a nice and regenerated liver, and you see the lung nodules, the same pictures in 2023. This summer, the nodules in his lung are virtually the same, never any change. His liver looks magnificent, and his CEA levels have been consistently low and normal ever since. So I think it's a very good example of showing that you can actually cure patients with transplantation for colorectal liver metastases. And the other thing, you can actually do it by novel techniques like this. So to conclude, this is a technique that might be a possible strategy to increase the availability of grafts, but it should be reserved for patients with a low MELD score and preserved liver function. And you have to consider portal hemodynamics to avoid small size syndrome. Live donation and minimal invasive surgery are possible refinements, and this is still a work in progress. And we need to have prospective trials and international registries to develop this further. But it essentially provides the combination of reduced living donor risk and no waitlist harm, which is a very attractive goal. So this is all I had to say about the repeat technique, and I'm happy to take any questions. Thank you very much. You're muted, George.
Thank you very much, Dr. Lena, for a very impressive presentation. We'll have all the questions and answers at the end. We're going to move on with the next presentation. We'd like to welcome Dr. Martin Hurdle. Dr. Hurdle is the Chief of Abdominal Transplant and Hepatobiliary Surgery at Tufts Medical Center in Boston, Massachusetts. His clinical focus areas include kidney, liver, and pancreas transplantation, as well as complex hepatobiliary surgery. He has been the recipient of several awards, including the annual ICUR Achievement Award in 2016-17. Dr. Hurdle is a member of the International Liver Transplantation Society, American Association of the Study of Liver Disease, the New England Surgical Society, the Transplantation Society, the American Society of Transplant Surgeons, and the American College of Surgeons. Dr. Hurdle, thank you for coming.
Thank you, George. Thank you to the ACS for allowing me to present. And the title was initially different, but we thought that this presentation would be more helpful for the general liver surgeon out there, a procedure that can be used more often than it is used currently, and I'm happy to present about this. Now I'm trying to scroll. Here we go. So the liver anatomy obviously is not known forever. There's Andreas Vesalius on the left, 1543. Glisson, we know the Glisson triad, already a development here, how much more we knew about it. And really Claude Cournot was the one who described first the liver segmental anatomy, and he was really important in bringing us to the next level. He did casts of livers. Here is a picture shown of the hepatic veins, as you can see, right, middle, left hepatic vein. And that in the end allowed us to develop a segmental anatomy understanding. And here you see the meta-atlas, how it is more and more developed. And here I show you Kant-Lee's line, because that is interesting. The division between right and left liver, anatomical division line, is not visible on the liver, obviously. And this is what he wrote in 1897, that basically in a patient who didn't have a portal vein on the right side, the left side would, or the contralateral side would hypertrophy, which is also important for my presentation, because indicating that if you don't have a portal vein, the liver health is impaired. And what we then did with my friend, Dr. Eric Schade, he probably was at the meeting in Zurich as well that Dr. Lina described. We did an animal model because we didn't know really what happens when you do a portal vein ligation in planning for an extended liver resection. And the situation is this, that we did an animal model and did in one group a portal vein ligation, and it was in the pig, and just left the right lateral segment. So the pig is different in the anatomy. It's the right lateral segment, you will see in the next slide. And the other group was portal vein ligation and hepatic vein ligation, so double vein embolization. And you see that the recovery after only 7 days, portal vein ligation has maybe a 25% increase, and the double vein embolization leads to an increase in liver volume on the non-treated side to about 90, 80, 90, almost 100%. And here you see after this is in the pig, we took trypan blue and infused it through the portal vein, and you see that only the right lateral segment, which is in humans the left lateral segment, this small piece is perfused, and there's no crossover into the treated or into the cancerous side, you might say. And you see what we found is that the development of collaterals between portal vein ligation alone and portal vein and hepatic vein occlusion is different. And here, number of collateral tufts. Those are collaterals in the portal vein system that form. And you see it that many more of those collaterals develop per visual field in the portal vein ligated liver compared to the portal vein hepatic vein ligated liver. So you in the range of 5 per liver visible towards 4 times more portal vein alone. And those are those tufts. So what we did basically what Cournot had done. We put acrylic into the organs. This is the portal vein is red. And you see those tufts here, basically collaterals from the right lateral segment in the pig to the healthy, to the portal vein ligated side. So this side has no portal vein, and this side has a portal vein inflow. And you see that this is not visible at day 1. We did obviously control group. Those don't exist, but within a few days, and this is day 7, those, we call them tufts, vascular nests develop, and that basically then diverts the flow from the non-ligated side to the ligated side and abolishes a bit the effect of portal vein ligation. However, if you, and I think I have one more picture here, similar, you see how dense those vessels are and how the connection here is. And basically, if you do a double vein embolization, then you push the blood flow from the cancerous side to the non-cancerous side, simply because the only flow that is left is the arterial flow into a tumor like this. You see an arterial flow, but everything else is stopped. There's no portal venous flow into the area that is to be resected. So the contralateral side will get all this flow, and there is no collateral formation as much, simply because there is no outflow. The blood cannot go, if it were to go from healthy to diseased, it would not be able to leave the liver. So it has to go from the liver side, from the cancerous side to the non-cancer side. So a patient like this, it's a hepatitis B patient, a large 15 centimeter HCC. It went to the border. I will show you to the right hepatic vein. You could say you could just do a non-anatomic resection here. But again, as I said, the right hepatic vein was very close, and all this liver down here would not have good drainage a bit to the middle hepatic vein. But it is much easier and much safer if you are able to remove the right side without having to fear of a penalty. Here you see it here, and you see the hepatic veins here going in. And basically what we did a portal vein. This picture is terrible, but what you see here is a plug that was put in the right hepatic vein. And this plug you will see later. And then there is the embolization of the portal vein. So the hepatic vein occluded with this Amplatz device, it's called, and this is occluded with coils and chemo glue. And here's the resection site. You see the hilum, the artery, the bile duct. This is the resection. So the tumor is gone. A small piece of liver is left behind. But here you see the tumor, and you see the coils, and you see also this Amplatz device. You see the two bellies, and it's hidden in the end pieces are hidden in the right hepatic vein here. But you see how close the tumor went to this middle hepatic vein. So I think it was the right thing oncologically to resect it. And the liver regenerates extremely well within 1 week. So we do this 1 week before the expected resection, which is different from portal vein embolization alone, where you usually wait 6 weeks, and the size is comparable, at least, if not better, to a 6-week portal vein ligation alone or embolization alone. So you see the left lobe is very big. There's still some, this is the stomach, but there was some ascites on the cut surface. And you see how segment 4 is abused here, despite the portal vein was patent, but you can just get away then with having segment 1, 2, and 3. Here's a coronal image. And here's another patient who is a 72-year-old patient, had chemotherapy for over a year with cisplatin and I forgot what the other drug was, combination therapy, and had also received Y90 in the right lobe. This is a bile duct cancer. The problem was, and we didn't know at the time, that he was fibrotic stage 3 fibrosis, and we did a double embolization on him. Here's another picture, and left lateral was really the only part that was could be left behind. But in a 73-year-old, he was felt before I saw him that he was unresectable. And this is a specimen in the end that we removed. And you see the big intrahepatic bile duct cancer. And here is now you see this Amplatz device. You see one end, the other end is still lodged into the right hepatic vein. And afterwards, he also developed a size because of the fibrosis that he had in his liver. But he has recovered. He's now 2 years out and is still tumor-free at this point, and is having a good life. Goes to Vegas for entertainment. The reason why I present this is people might say, oh, this is all resectable without any fancy stuff. The left lateral segment you might get away with it. But doing this pre-treatment allows you, similar to what Dr. Lena showed, that he invokes regeneration of the left lateral segment and doubling in size before he removes the right lobe of the liver, the tumor-containing native liver. And this is a similar approach, that we grow the liver before we do the surgery, and we can grow it very quickly. And it is much more stable, the growth, and more reliable, and it's much shorter. As you know, when you take long to resect and you have 2 months or so between embolization and surgery, some patients might drop out. So this will reduce that danger. But of course, it's a team effort. Oncologists, interventional radiologists, radiation oncologists, potentially radiologists, and the surgeon. We all have to work together. And but I think the more we use it, the less post-operative liver failure we will see. And I'm happy to take questions. And thank you again.
Thank you very much, Martin. This is very impressive work. And we'll have the questions at the end, but first we're gonna hear from Dr. Yuman Hong, who's gonna be our commentator and help us understand the significance of what we've seen. Dr. Yuman Fong is chairman of surgery at the City of Hope Medical Center. He's known for his work that helped prove that liver resection can lead to long-term survival and cures for patients with metastatic cancer to the liver. For his clinical accomplishments, he was awarded the Leighton Brackett Master Clinician Award from the Society of Surgery for the Alimentary Tract. He has helped design many novel surgical tools, including surgical robots, and his laboratory designed cancer-killing viruses and immune cells. His work in medical engineering has led to his election to the American Institute of Medical and Biologic Engineering. He has co-authored over 1,000 articles and 22 textbooks, which have been cited over 90,000 times in the scientific literature. For his contributions, he has been awarded the Shipley Award from the Southern Surgical Association, the Flance Carl Award from the American Surgical Association, and has been elected to the American Society of Clinical Investigation and the National Academy of Medicine. Dr. Fong, the floor is all yours.
Thank you very, very much, and for that kind introduction. I just want to point out, even though we are here gathered to talk about extreme liver resection, what we're really talking about today is how to make it safer for patients. And there was a long, long time when we were doing extreme liver resections to the tune of 10% mortality. That was back in the 80s and the early 90s, when we were doing resections and transplantation when it did not make biologic sense, when patients were dying of their cancer. What we're talking about today are techniques that allow us to do extended indication resections and transplantations that allow patients to live longer, the most important parameter, and to survive their surgery and to recover faster. That's what we're talking about here today. So I have two questions for Dr. Lenny. And first, again, with the left lateral sector being the target for resection and transplantation, does it even have to go up into the left into the right upper quadrant? And why take out the first part at all? When I read your paper in 2015, I knew it was going to be a landmark paper, that was going to transform transplantation as we knew it. But I didn't quite understand why you were putting it back up in the right upper quadrant to start with. And obviously, everybody succeeded, so it's fine. But is there any advantage to doing that? Should it be somewhere else? The other that I'm wondering about really is the biology of transplantation. And are you measuring circulating tumor DNA levels in the patients before you do explant? Because that would actually give you the a parameter to look at to see who will recur in the new liver. Okay, does it correlate to circulating tumor DNA? And then, are you doing anything extra on the explanted liver? Are you doing a Y90 ablation of all the tumors to decrease the level of circulating tumor DNA and possible tumor seeding to a new piece of liver? You're on mute.
Thank you very much, Yuman, for these excellent questions. So I'll try to take the second first. So this story about transplanting for colorectals is beginning to get old. So we started back in 2005, and obviously at that time, liquid biopsy and circulating DNA was not really available to that extent. So what we have been doing is make sure that we have banked enough tissue. So we're currently doing it on the population, because I think basically you have to have numbers before we do that analysis really to tell. So basically, what can you use circulating DNA for? Well, I can envision two things that you could. I don't think it will be any specific marker itself, because we have been looking at DNA in colorectals for years. But you could argue that high titers of circulating DNA might be a very bad prognostic sign. And Cleveland has done a little study that was published some months ago, where they showed that after transplant they had a proportion of patients were completely cleared. Some were without recurrence, but they had recurrence of DNA, so that will be exciting to follow. But I think in the repeat setting, I mean, you have sort of started the procedure, and if you don't know if it's going to be cleared before you have taken out the remnant, right? So I'm not confident whether it's going to change very much. I think we should think of transplants for colorectals as addressing the Achilles heel of liver resection, because to my mind, the Achilles heel of liver resection is understaging of the disease, meaning that we think that the patient has this and this number of lesions and we can clean, do a two-stage and clean. But it is clearly shown that there is a systematic understaging, and this tendency to understage is actually a function of the number of lesions. So the group in Rochester showed that in a systematic investigation of expants from transplant patients with colorectal liver metastases, about 70% of those having complete radiological response had living tumor cells, and 50% of the patients had non-diagnosed lesions. So this is a big problem. In Toronto, they have a trial where they do living donor for colorectals, and they are very stringent in terms of making sure that they are not technically resectable. They have looked at those that were deemed that were resected instead of transplanted. They are similar in every way as the transplanted, but in the resected population, the recurrence frequency at 1 year is 86%. So I think we have to regard transplantation as addressing the problem of misstaging. So really, what we should start talking about is. It's not whether technical resectability, yes or no. We should talk about biological resectability, and then choose whether it should be a partial resection or 100% resection. The first question, could you repeat it?
Why does it have to be in the right upper quadrant?
No, it doesn't have to. So you could do a posterior right section. You can remove that and put the left lateral there. Doesn't matter at all. And in fact, often when I do pediatric transplant, if it's a bit too big, I would flip it over and put it on the other side. So you are, I mean, it's just our imagination that sets the borders.
So Dr. Hurdle, a superb contribution.
If I may, Dr. Fong, if I might just add to this, because we have done, you asking where's the location of the graft. So we have done at the University of Essen in the late 90s, we did 2 transplants in acute liver failure patients with a split graft into the right lower quadrant.
Yes, both helped with some of those in the 90s.
Yeah, see, both well, let's see how your experience was, but we had both failed because we think that the venous congestion is more. You're further away from the diaphragm.
Yes.
This is actually the same reason why we now do pancreas transplant, always very close underneath the liver. We used to do bladder drainage in pancreas transplant and so forth, but we had venous congestion and venous clots sometimes. And so those livers did not work in the long run, because when the patient was getting up, the column of blood pushing was high. And I see that Dr. Lina is agreeing. So that's my contribution to the location. So I think it should be, we actually have done it in a patient with hyperoxaluria. We just put a left lateral segment in and left the right low, but we resected left lateral and then diverted the portal flow 2/3 left lateral, and it worked fine as well. So I can only congratulate you. This is fantastic, and I have learned a lot this morning, so I appreciate.
So Dr. Hurdle, superb contribution in terms of the two-vein embolization. I have 3 questions for you. Should we do it as a primary event if we were trying to grow liver? Or should we do it only when the portal vein embolization does not work? Okay, because when the portal vein embolization does not work, should we repeat it, or should we do a portal vein embolization and the hepatic vein? And lastly, I'm reading more and more and doing more and more Y90 lobectomies for primary cancers of the liver. And so that hepatoma you showed, I probably would have approached that either with a primary resection if the platelet count was high, or a Y90 embolization and lobectomy if the platelet count was low. Okay, and so how do you compare the two vein to the Y90?
Yeah, so the first question, I would just always do double vein embolization if you think the remnant liver, the future remnant, is not big enough. I don't think you lose anything. The IR folks, they used to, in the 90s, we used to go in, first surgery, we ligate the right portal vein, even divided or not divided, and that was it. And obviously, if you don't go into the periphery of the portal vein distribution, there is a lot of crossover from the not ligated part of the liver. And now the radiologists use coils and glue and go as far in the periphery, and they know if they don't do that, there will be a lot of crossover. However, my proposal, but I don't have the data yet, when you do the hepatic vein embolization or occlusion at the same time, you will not have a good to bad flow, or from the to be preserved side to the cancerous side, you should not have flow, because technically it should be impossible for blood to go from the future liver remnant to the cancerous side, because there's no outflow. And in fact, there is hepatic artery flow that still pumps blood into the cancerous side. We have not seen in the patients we have done, and it's a number now, the liver enzymes do not increase, the liver function stays stable. The patient doesn't even feel it. Obviously, it's an outpatient procedure. That is there's in the chat a question: how does it compare to ALPS? Obviously, and it compares very favorable, because you don't have the morbidity associated with ALPS. And the liver regeneration, I think, is at least as good as with ALPS, because you don't have this trauma of surgery that hampers regeneration to a certain degree, because it's such a minimal invasive procedure. So if you do portal vein embolization, which is probably the harder part of the embolization procedure, but I think one could just put in the future an Amplatz device in the right portal vein, for example, if you were to treat a tumor on the right, in the right hepatic vein, and that's it. You don't need this several feet of coils and this hard work for the radiologists. However, they are not there yet, the radiologists. They still want to do the portal vein embolization the way they do it. And I forgot your second question. I'm sorry.
The Y90.
Yeah, Y90, I think, should work very well. You could, the only concern there I have is that you could get a little Y90 into the healthy part of the liver. That could be a concern.
No, we are actually now putting it into the good part of the liver. so that we would end up having a complete atrophy of the right liver as well as the tumor for primary tumors. But let me turn this over to George for the audience questions.
Thank you very much, Ewan. So one of the questions which Martin answered was a comparison of the double vein ligation to ALPS and the liver remnant growth and complications. I guess one question I have along these lines is ALPS kind of becoming old news and less favorable?
Yeah, if the question is for me, that's what I think. I would not know any case anymore where I would do an ALPS procedure. And we have done those a number of times when it was coming up, but the mortality obviously has to be much higher and is higher, and the regeneration is not better. The rapid regeneration that we see, within a week, we are planning the surgery, and usually we do surgery 10 to 14 days after the embolization procedure. So we don't miss ALPS.
Moving on to another question for Dr. Lena. Do you see us moving into other types of metastatic disease apart from colorectal cancer? The way that the surgical technique is progressing and the understanding of the biology, as you very correctly mentioned. Are you any thoughts about looking into other types of metastatic?
Well, I think many centers haven't really taken up neuroendocrines, but we adopted the Milan principles with a slight modification, meaning that we are not that concerned about age, with numerical age, meaning so we are looking at biological age, and then we also have accepted patients where the primary cannot be located. And we have now done 26 cases since 2013. We have a 10-year survival of 100%. And we have just 2 recurrences in that population. So I think neuroendocrine metastasis is an excellent indication, really, and probably underutilized, because we know that in these patients in particular, understaging of the disease is really limiting the usefulness of resection. So their transplant can really play a big role. For other cancers, time will show. I think there might be maybe a little role in GIST or something like that, but we haven't gone into other metastatic cancers, really.
Great, thank you.
May I ask a question, George?
Yeah.
For Dr. Lene.
Yeah.
You sometimes employ split liver grafts. In the United States, yes. It would be extremely difficult to get a split because the organs, which is in contrast to when I was still working in Germany, where an organ would be allocated to the transplant center and not to a specific patient. Here in the United States, it's allocated to a specific patient, and it is hard to sell the patient with a MELD of 35 that you're going to get almost a full liver, but we need left lateral. You're going to save a life, sir or lady or madam, and they don't. That would be fraught with legal implications. And so, how is the current Eurotransplant? I don't know whether you're in Eurotransplant in your country. So that would be interesting for me to understand.
Yeah. So the situation for we are outside the confidence interval, so to say. So in Norway, we have a population of 5.5 million and 1 center. And we are not part of Eurotransplant. We are part of what's called Scandia Transplant, which is Sweden, Denmark, Norway, Iceland, Finland, and recently also Estonia. So basically, we have in the transplant community, we have 28 million people. And the reason for having this organization is basically with just two things. It's for perfect matching of kidneys. The other is to have an urgent listing system that functions for urgent listing and pediatric transplants. But in all the centers, we have center-based allocation, meaning that here in Oslo, we decide who gets the specific liver. And that allows us to have a much more dynamic waiting list system. The other thing is that we don't use MELD allocation at all. We published back in, I think, in 15, 16, we published a Nordic liver transplant experience, and MELD has no impact, meaning because our median waiting time has varied from 30 to 50 days. So obviously, if you predict 90-day mortality, it's not going to be very meaningful. And the waitlist mortality in the Scandia system is about 2.5 to 3%, way lower. So we are in a very fortunate situation. I think that's why we have been able to look at these oncological indications.
Yeah, I see. Thank you.
Another question from the audience: how long does it take tumor recurrence after the rapid procedure?
There are two ways to answer this. The most honest one is to say, I don't know, because we don't have a lot of data on that specifically, because the indications for doing the rapid have mostly been slightly extended. But it's a valid remark. Could you actually have increased recurrence because you have this regeneration in the beginning? And my answer to that is in ALPS, in portal vein embolization, in double vein embolization, we see this all the time. You should worry about the mechanism of having tumor cells going to the future remnant. But it's not really an issue in short intervals, because the tumor cells doesn't jump. And I think the way to avoid this is actually how you select your patients. You should never transplant the patients where you think you have circulating cells or an unstable situation. So I think it's a matter of patient selection. We have looked at the right liver in the patients we have done rapid, and we have not been able to radiologically show that there is an increased growth in the interval period. So I think it's a problem that is of great theoretical interest, but I think it can be addressed by selection.
Thank you. We have another question for Martin. When you do the double ligation, how often do you repeat the imaging and the FLR volumetry? And when do you do the first study after embolization? And also whether you've had any experience in children with this technique.
Oops.
You're on mute, Martin.
Now I'm unmuted. Can you hear me now? So I can only think that the regeneration is more rapid in younger patients, but I have not done this procedure in a pediatric patient. So we do, once we have identified a patient that this double vein embolization is beneficial potentially, we do the double vein embolization. It's on the same day. You could do it in 2 steps, but we have not felt that that's indicated or needed because the liver is not suffering because of the double embolization. As you saw, one of my patients was a fibrosis patient, and then a week later we do imaging, and then we measure obviously time 0 liver volume and then the volume 1 week later. And in those 2 patients that I showed you, one had an 80% increase in volume, and the other only a 60% increase, the fibrotic patient. However, it was felt that overall the lobe was large enough to sustain him. Simply at this point, we still didn't know that he had this fibrosis. There was never a biopsy of the healthy side, which it could be entertained and might be a good idea to know what quality of liver you're dealing with. I've done it in cirrhotics, frank cirrhotics, and the liver did not regenerate at all or very poorly. And then if that happens, you cannot do the procedure. But basically within a week, we know what's going on. But the generation then regeneration goes on. If you then do another image 3 weeks out, which we do usually 4 weeks after the surgery, the time 0 image for tumor follow-up, then we see that it is enlarged much further, usually another 100% at that point compared to the initial pre-double embolization time point.
Great, thank you. We have a lot of questions. Unfortunately, we don't have time. And the very last one, which is more of a statement regarding the discussion before the splits, it's from Dr. Martin Weil from Germany, saying that in Germany we have not often but regularly liver grafts which go to the center transplanting the child during the split, and then the right lobe to the next one. Tumor transplant and Eurotransplant only within studies. And I think that shows the differences between the different donor type and organization between the different systems, not just between Europe and the US, but also within Europe. At this point, I would like to thank our speakers and our commentator, Dr. Paul Daglina, Dr. Martin Hurdle, Dr. Newman Fung, and for very interesting presentations and discussions. And I will now turn it over to Jesse for final announcements. Thank you.
Thank you all for joining us on today's webinar. As mentioned at the beginning of the webinar, these presentations have been recorded and will be posted on the ACS YouTube page. Additionally, you may also view past webinars on the ACS YouTube page under the Global Surgery playlist. I would also like to highlight that this year our residents can become members of the American College of Surgeons for free. On here is just some information on that. And then lastly, if you have any questions or feedback on this presentation, please contact myself or any of the IRC staff, and our information is on the screen. Thank you all again so much for joining us for today's webinar, and we hope that you have a great day. Thank you. Bye-bye.
Thank you. Bye-bye.
Bye-bye. Bye-bye. Good to see you.